tonight. Our next speaker is Dr. Emanuel Menga, who is Associate Professor at University of Rochester. He will be giving us a talk on PJK, risk factors and prevention, updates on, in particular with an update on pediatric focus.
Thanks, Lionel, and thanks everyone for coming. Another great meeting. So the talk will focus on proximal junctional kyphosis. We'll discuss a little bit of adult and pediatric, but maybe more towards the pediatric side. I have no disclosures related to this topic except we have a published article in JBJS regarding proximal junctional kyphosis. Still doesn't answer the question, but at least just a broad review of the topic. So beginning first, so proximal junctional kyphosis, so moving forward, I'll just describe it as PJK. PJK was first described in 1994 by Lowe and Castaigne, and this was found after correction of Sherman's kyphosis greater than 50 degrees using the CD construct as Serena described to us, give us some historical perspective on spinal instrumentation. So the CD construct is they're just using rods and hooks for fixation. Just posterior element fixation or posterior column fixation. So how do you define PJK? So PJK, the most commonly used angle is a 10-degree angle, and the angle is measured from, let's see if I can, from the inferior end plate of the UIV, which is the upper instrumented vertebrae, to the superior end plate 2 levels above the UIV. So UIV is right here, inferior end plate. The sagittal cob measured to the superior end plate 2 levels above the UIV. And if the angle is greater than 10 degrees or at least 10 degrees greater than the preoperative angle, then it's considered PJK or proximal junctional kyphosis. Bridwell described 20 degrees as a critical angle, and Hagelson also described 15 degrees as a critical angle. The reason for this is if you look at the outcome studies, most patients are asymptomatic and require no revision, so why not use an angle that better describe maybe someone who needs revision or surgery or someone with symptomatic PJK. Other descriptions, so when you're dealing with your residents or your fellows or even your colleagues calling you for consult, we use different terms sometimes to describe PJK. Which, if the resident calls me and tells me I have a patient in the ED with a proximal junctional failure, to me that's different from saying PJK because the failure means it's someone who needs surgery or someone who's symptomatic. So PJF is also another term used to describe PJK, the more severe or symptomatic form. Topping off syndrome or proximal junctional acute collapse. So here's an example of a patient we treated during residency. This is slides borrowed from Dr. Kabesh. Had, I think it was L to the pelvis, developed PJK, was extended, and just kept progressing to the occiput. Here's an example. I do majority adult deformity. So for PJK, for this topic and for this presentation, I borrowed this case from a friend at Miami Children's. And this is a patient who presented to him. We don't have the original x-rays because the patient presented after surgery. Had surgery somewhere else, had a T3 to L4 fusion surgery in 2017. And immediately after surgery, per the patient noted, or the family noted, they were told there was some failure above the construct. In 2018, complained of neck pain and noticeable worsening of clinical proximal angle, and x-rays were obtained. And in 2019, presented with this, with the 40-degree proximal junctional curve, and was stable at 2020. So going into, move this forward. If you look at the epidemiology of PJK, this is using 10 degrees as the critical angle, focusing on adolescent patient or pediatric patients. The prevalence is reported at 9.2 to 46%. Using 15 degrees as a critical angle in AIS patients is reported between 5 to 8.2%, and looking at patients with Sherman's kyphosis reported between 30 to 32% of patients with PJK as far as incidence. Timing of PJK most commonly occurs within the first year of surgery, and majority of the angle within the first 3 months of surgery. So in this study, so there are very few studies in the pediatric population with PJK, but in this study, looking at idiopathic scoliosis, both 50%, this study included 50% pediatric and 50% adult patients, demonstrated 43% incidence of PJK within the first year of surgery. So mode and location of failure. So if you're looking at different aspects of the spine, so in the upper thoracic spine, it's typically associated with soft tissue failure. In the proximal thoracic spine between T2 and T5, it is some proximal failure or some ligamentous complex failure leading to PJK. In the thoracolumbar spine, it's typically associated with fracture, which could be fracture within the screw bone interface or compression fracture at the top level with screw cutout. There have been some attempts to classify PJK, so this is from the group at HSS, with the classification using the grade of the curve and also the type of curve. So grading just looks at the angle, and with grade A, B, and C, looking at the severity of the angle and the type of curve of failure, looking at whether or not it's a soft tissue failure or ligamentous failure, or is it a bone failure, or is it a hardware or bony failure combined. When we look at literature, try to determine exactly, one thing we know in general we're lacking, especially in orthopedic literature, is level 1 studies, which are typically tough to get, especially with surgery. When you look at various studies, there are numerous studies out on PJK. If you pay attention to the statistical analysis using univariate analysis, so focusing on pediatric patients, so these are all the univariate analysis for adult and pediatric patients, but focusing strictly on the pediatric patient, thoracoplasty, the magnitude of a thoracic curve correction, pedicle screw fixation at the UIV, posterior spinal fusion, LIV at the sacrum. These are all variables that have been shown to increase risk for PJK in pediatric patients. When you look at multivariate analysis, taking into account some of the confounding variables, just a lower risk of grade has been shown as a risk factor for PJK in the pediatric population. So when we look at different risk factors that can lead to PJK, we group them as patient-specific risk factors, surgical risk factors, radiographic risk factors, but we truly do not understand the relative risk for each factor and how it leads to PJK. So when it comes to patient-specific risk factors, gender, age, BMI, osteopenia, osteoporosis, which this is something you commonly see in the adult population, sarcopenia, alcohol use, cigarette, curve flexibility, these are all different factors that we would consider patient-specific risk factors. Surgical risk factors, we talk about the type of instrumentation, whether you're using screws and rods or hooks and rods or hooks or hybrid between hooks and screws and rods. Anterior surgery, posterior surgery, anterior and posterior surgery, proximal instrumentation level, the level of the UIV, pelvic fixation, and also looking at the integrity of the posterior longitudinal ligament. Then the question is, how does pelvic fixation affect or cause PJK? Well, if you fix the patient down to the pelvis, there's really no motion segment besides the proximal level, and that's why there's some papers reporting that fixing to the pelvis increases your risk for PJK because your risk for DJK is pretty minimal in that case, so it can only fail proximally. When we look at radiographic risk factors, this picture describes a cone of economy. It was described by Jean Deboussé. And what this describes is so the cone of economy is an angle projecting from your feet and upwards. So you see this circle, and you also see this ring, and this ring around the waist. So the cone of economy is a projected angle surrounding the body, which the body can sustain without external support and with minimal pain. So you think of, you've seen the Michael Jackson video, is leaning and dancing. So if you can move within that range, the cone of economy, without pain, without a walker, without a cane, without any external support, and not feel pain, then patients, you can, that's what we talk about, you can fuse patient with some kyphosis to minimize risk for PJK. You can fuse them with some hyperlordosis or with some coronal imbalance. So long as that patient is within that cone of economy, they're asymptomatic, and so we do not need to bring every patient to a perfect alignment. Current literature is largely, when we look at radiographic risk factors, most of the current literature is largely based on using the Schwab criteria for correction. So we look at the C7 plumb line, thoracic kyphosis, lumbar lordosis, pelvic incidence, which we use to determine the lumbar lordosis, SVA, or the sagittal vertical axis. So now focusing on with the risk factors and looking strictly at the pediatric population, and just a quick review on how we look at our studies when we look at research studies to see what has been done and what has been shown to potentially increase or decrease the risk of PJK. Just a brief overview of how we evaluate studies. So we look at the grade of recommendation. So grade A studies is very far, we have very few of those in spine, and this is based on strictly level 1 studies. Grade B recommendations, so it is fair evidence, level 2 studies, level 3 studies. So a majority of the studies we have with regards to PJK are level 3 studies. So it falls within grade B recommendation. And you have conflicting evidence or poor quality. This are level 4 and level 5 studies. And grade I is the insufficient evidence to make any recommendations. So looking at a systemic review out of Cleveland, looking at it's more of almost a meta-analysis, but looking at all the studies available on pediatric PJK. If you look at the incidence for PJK, it's reported somewhere between 6 to 58% rate of PJK in patients with early onset scoliosis. And this is looking at a total of 16 studies with about 1,230 patients, with mean 23% of incidence of PJK in 16 studies. Looking at AIS patients with 3,891 patients, is reported between 0 to 46%. And with only 12% out of 199% requiring revision surgery, which brings back to why are we interested in PJK, or why do we care about PJK if majority of the patients have good outcome, regardless of the PJK. So focusing on the pediatric patients with early onset scoliosis, we know the higher the number of distractions, which has been reported as greater than four distractions for patients undergoing growing construct, can increase the risk for PJK. This is based on grade B evidence, so these are predominantly level 3 studies. Disruption of the posterior ligamentous complex, greater sagittal plane correction, specifically in this case for EOS, sagittal plane correction, specifically SVA. So greater than 20 millimeter correction of SVA increases your risk for PJK. Looking at AIS patients, higher preoperative thoracic kyphosis, lumbar lordosis, long construct, greater sagittal plane correction, posterior instrumentation and fixation, those are all risk factors using grade B evidence. So how do we reduce the risk for PJK? We know various things we look at, taking into account patient-specific risk factors, radiographic risk factors, surgical risk factors, fixation technique, restoration of global sagittal alignment in adult population, especially looking at patients' bone quality and fixation points. Those are all significant risk factors, as significant tools that we can use to reduce the risk for PJK. So fixation or prevention techniques, pedicle screw, hooks, tethers, or vertebroplasty. And let's go to this. So pedicle screw fixation allows you for rigid fixation with the benefit of high fusion rate. But there's also the theory that by creating a rigid fixation at the top of your construct there's some flexibility just above your fixation point, and it can actually increase your risk for PJK. Placement of pedicle screws in order to place that pedicle screw, depending on the surgeon, sometimes it comes down to surgeon experience, or depending on the technique you're using, there's disruption of the facet capsule at that proximal level, and by so you disrupt your posterior tension band and increases your risk for PJK. Other instrumentation techniques, using hooks, there's very good level 3 evidence, but not strong enough to consider grade B evidence, so it's mostly grade C recommendation with use of hooks. If you look at instrumentation techniques right now, by far hooks are considered to be the best technique to prevent PJK. But again, this is based on grade C recommendation with level 3 evidence, but that's the best we have. So here are some studies comparing use of hooks versus use of hooks and screws, a hybrid construct, versus use of strictly hooks. So this is going back now to the CD construct. And it was shown that using strictly hooks actually is the best to reduce the risk for PJK. And also with use of hooks at the top of the construct at the UIV versus use of screws. There's recent evidence, not long-term evidence, suggesting that use of tethers at a proximal level can provide maybe a soft landing with your posterior ligamentous complex and reduce your risk for PJK. And especially using more tethers at the top. So the more you use, the less likely you are to develop PJK. But if you think about it, I have never used tethers before, but if you think about how you go about placing those tethers, you end up disrupting the natural tissue within that level. So it's the ultimate goal is to maintain the patient's normal tissue. But if you're disrupting the tissue to place the tethers, and again, we only have 1 and 2 year follow-up studies. We don't have long-term studies to show that this provides significant improvement or reduces your risk long-term for PJK. Vertebroplasty. When vertebroplasty was initially was described by Kabesh et al. At Hopkins, the 2 year follow-up studies and 3 year follow-up studies showed great reduction risk for PJK. So it was being observed as the thing to do at the time. But when you follow with the follow-up study that came out several years later, 5 to 7 year study demonstrated that there was actually no significant reduction in risk for PJK. So vertebroplasty is not, it may reduce your short-term risk for PJK, but not long-term risk for PJK. We briefly described, the last 2 speakers described the global sagittal. We talked about global sagittal, restoring your global sagittal alignment, which, as we discussed, this is currently mostly based on the Schwab criteria with various sagittal spinal pelvic alignment criteria. And also, this is mostly, if you look at the study by Ilya and Lenke, looking at SVA, which we know as, commonly described, life is a kyphosing event. So mostly in the adult population, we know as we get older, we tilt forward. And when we take some of these patients from, SVA of 20 or of maybe 15 centimeters and you bring them back to 5 centimeters, maybe that increases their risk for PJK. So maybe undercorrecting some of these patients reduce their risk for PJK. Other techniques, just for the sake of time, with restoring sagittal alignment is using the gap score, which, as the last speaker mentioned, gap score, restoring the gap score has shown to reduce the risk for mechanical failure, including PJK. So the more closely you can reduce the patient's gap, get the patient's gap score closer to the recommendation that's proportional to the gap score with the sagittal alignment, you reduce the risk for PJK. And this is using the gap score and comparing this to health-related quality of life measures, showing significant improvement. So what do we currently, as far as prevention, we currently have very small studies, mostly case series, low level of evidence studies with grade C or grade B recommendation. We do not have any grade A recommendation. Limited short-term follow-up studies. There's no consensus guideline on prevention of PJK. So future directions, what can we do for the future? Really, we need to validate and define threshold for patient-specific correction, so including SVA, thoracic kyphosis, lumbar lordosis, PI minus LL, T1PA. Taking into account patient's bone density and also incorporating Hounsfield unit and also validating Hounsfield unit may be critical in figuring out ways to reduce the risk for PJK. And maybe focus most of the studies on clinically significant PJK and PJF. As we've shown, majority of the health quality of life or outcome studies have demonstrated no significant difference between as far as clinical outcome for patients with and patients without PJK. So maybe focus our attention on patients with symptomatic PJK. So personal approach for all patients, for majority of my patients, which are adult patients, we get a DEXA scan, and we also we get a DEXA scan if they have scoliosis. We send them to our metabolic bone clinic, and get them started on some anti-resorptive medication for treatment, also vitamin D and calcium. In addition to the DEXA scan, when we're planning for surgery, we also get a CT scan where we measure the Hounsfield unit, because even if I'm planning to do a T10 to pelvis, but my T10 is giving me a Hounsfield unit of 100, I might want to consider going a little higher, maybe the T9, if my T9 has a better Hounsfield unit for better fixation at the top. Intraoperatively, as Dr. Trinellis mentioned, when decompressing C4-5 to minimize your risk for C5 palsy, when I do exposure with the fellow or with the resident, I will typically, have two bovies going at the same time, and I tell them, you dissect from right here. So if I'm stopping at T10, the exposure on their side stops at T12 or L1. When it comes to exposing the proximal level, I do it myself, because I don't necessarily, in placing pedicle screws, I don't need to see the entire aspect of the TP and also the facet joint at the levels if I'm doing a T10 to pelvis. At T9, 10, I just need to see just where I know my pedicle is supposed to go. So personally, I use pedicle screws because for me, it works well in my hands. I've never used hooks, so you really have to do what you think works best for you. And I try to place the screws at the UIV in a more anatomic position. So instead of placing the classic just below the end plate, I do a slightly more anatomic placement, and to a certain degree, I feel that reduces the risk for the screw cutout at the top, so especially if you're stopping within the thoracolumbar junction. Post-operatively, these patients are placed given a Jowett brace. We don't have any strong evidence to support that it makes a huge difference. And patients are instructed to only wear the brace when they're out of bed and walking. So sitting in bed and sitting upright, they don't have to wear the brace. Continue calcium and vitamin D. And going back to the case I showed earlier, so this patient ultimately underwent revision surgery and extension of the fusion to T1, but using navigation to navigate the screw to avoid having the screw go more closely into the end plate. So that's another technique you can incorporate into your practice when you do a revision surgery for PJKs, maybe incorporate some navigation. So because as we know, some of these patients, if you do multiple passes through the pedicle is destroyed. Or if it's a dysplastic tiny pedicle, you want to get one pass and be done instead of doing multiple passes and compromising the pedicle at that level, and which can lead to a recurring PJK. Thank you. Any questions?
I have a question.
Sure.
Great talk. Regarding the cement fixation, it sounded like you've gone away from it a little bit, and I was going to ask you whether you guys have seen any issues with cement emboli. We, in our group, we started doing a little bit more cement fixation, and in the last couple of years, we had seen a number of cement emboli, and it's not a large emboli, it's more of an ARDS type picture, and we've kind of gone away from doing that. I know there is reports in the literature, but I was wondering if the guys that use it have seen or had any problems with that. And then just a comment regarding all the things that you're doing. It looks amazing. One of the things that I've started doing is using transition rods, so like 5.5 to 6.0 rods that are a little bit softer at the top, and leaving it, and and seems like the patients tolerate that really well at the proximal level.
So for I haven't used transitional rods, so that's the quick answer to that. I don't use transitional rods. When it comes to cement fixation, if the patient has poor bone quality, with most of the elderly patients, I still cement just to get better fixation of the bone, but I don't. So vertebroplasty, description of vertebroplasty is that you do vertebroplasty at the UIV and also 1 or 2 levels above your UIV. So it's not just cementing your fixation point, but also cementing above. So I don't cement above. I may do vertebroplasty at the level of the fixation just for better screw fixation, just like as you would do for a degen case, not deformity case. But I do not cement above because the evidence doesn't support it.
Maybe just a quick poll of the audience. For those who do adult deformity work, who routinely cement the UIV for a T10 to pelvis? And who never cement the UIV T-tendon pelvis? All the lanky fellows, it looks like. And then who sometimes cements the UIV, and then I want to hear kind of what the thought is there.
Yeah, so I sometimes cement it. I don't cement it all. I only cement it if the patient has bad bone.
Okay, and you
Yeah,
base
if the
that
patient
off
has
of your-
normal bone, Hounsfall unit looks good. Fixation point when I do not. I only cement for patients with poor bone.
And so just for a take home for everybody, what's your threshold for your DEXA or your Hounsfall units?
So DEXA and Hounsfall unit, the correlation is that if your Hounsfall unit is greater than 130, that correlates with good bone. So that's what I use, and anything below that I consider poor bone quality. DEXA, the worst bone, I would say, based on DEXA scan, which we know is very inaccurate, especially for patients with deformity. I think the worst patient I've had with maybe a DEXA of negative 2.8. But I've had patients with normal DEXA scan, and you get in there and you're doing your instrumentation, and it feels like zero, like there's no bone. You're pretty much putting the bone in the air, the screw in the air. Yeah, sorry.
Yeah, no, thanks very much for that important talk about a really important topic. So it's interesting that you choose to do it for patients that you're worried about their bone quality, because that's kind of what we found. So we just presented, I think at the Academy, that when we did, I do DEXAs in all my patients, so I'm going to do an adult scoliosis fusion on, and not all my colleagues do. So for the patients that had a pre-op DEXA, we found that using cement augmentation decreased their PJK rate, but only to the level of the patients who did not have osteopenia or osteoporosis. So you can't prevent it all by augmenting and that's one of the problems, is that you still have all these other factors, for example.
Yeah.
But you do it selectively for the patients that are at risk, and that might decrease it, but it can't eliminate, I don't think. I think there's still other factors like patient strength, ligamentous dissection, all those other things. But that's interesting that you do that as well, which is kind of what I've gone to now that we have that data.
Yeah,
Thank you.
yeah, no, because I think during the first meeting we had here 4 years ago, we, I think, polled everyone who gets a DEXA scan. I think nationally, very few people get DEXA scans, and I know that's something AOA was pushing pretty hard for, own the bone, and I get DEXA scan on every patient undergoing deformity surgery. And even a lot of my patients undergoing degen, like just 1-2 level, because it can play an important role when it comes to cement and arterioroplasty.
Yeah. I had a question. When you send someone for like the anti-resorptive therapy, like you have like a particular duration in mind, or do you look for a change in the ZRT score?
Yeah.
Like, because sometimes you want to get to the patients earlier, but like at what point, like how long do you?
Yeah, so I don't have any specific protocol for it. For some of the patients I'm really trying to avoid operating on, I tell them wait for about 6 months to a year. So I currently have a patient who came to me for a second opinion, already had surgery scheduled in Buffalo. Came to see me and I mean, you look at an x-ray, you look at there's no bone, but was never truly worked up. And I gave my opinion, but hoping that she doesn't ask me to do her surgery. And she went home and then called my office to schedule her surgery. I was like, no, I was just giving you an opinion. But now she wants a surgery, so we sent her to a metabolic bone clinic and started on therapy, and we're hoping we gave her at least about 6 months because she had very poor bone and bad scoliosis, so it will require a lot of correction. There's really no strong evidence to support any timing of surgery once you begin the anti-resorptive agents.